The topic that I'm going to cover in my 10-minute presentation is about gastric residual volume, and to try to convince you that routine measurement of gastric residual volume is not needed in present day practice. Now, it is true that there is an interplay of pathophysiologic changes and nutrition in the critically ill patient. The prolonged fasting and the suboptimal intake will affect the GI tract. GI dysfunction can occur because of hypotension and dysbiosis or affecting the GI flora, gastric and gut motility. And there are inflammatory changes that also occur that can affect the GI tract function. Now, there are multiple objections to enteral feeding, and they are listed in the literature, and you will know it from your own practice, where some clinicians are reluctant to feed enteral feeding. But the two things that have to change in the way we practice are the following. One is gastric residual volume, and the second is blaming diarrhea on enteral feeding. So I'll first deal with the gastric residual volume. Now, even though it has been mentioned for several years that gastric residual volume should not be given that much importance, concepts are difficult to change. There are barriers to change. Now, in this slide, where they did not look at anything to do with actually nutrition, but to provide solid food 6 hours prior to surgery or anesthesia and liquids 2 hours prior to surgery, which is what we are supposed to do. A lot of people in Australia, even in a quaternary care hospital, were reluctant, and they found it was mainly because of cultural concerns and gaps in knowledge. I wouldn't be able to help you with the cultural changes in your hospital, but I can certainly help you by sharing these slides with you about the gaps in knowledge which you can impart to the physicians in your hospital. Now, the first question is, because of dependence on gastric residual volume, is there a deficit in enteral nutrition intake? Absolutely, yes. In this Belgian study, current guidelines were followed, and there was a deficit in both proteins and calories fed enterally, greater in protein. And we know it is very important that the adequate amount of protein needs to be given. So, in order for you to do this, you need to have protocols. And here is a study from a major trauma center where they looked at close to 3,260 patients with 2,700 enteral nutrition days. And they find that if you have a multidisciplinary protocol, then the enteral nutrition delivery is achieved by 10%. And over 80% of nutritional goals were achieved. So I urge you again to change your protocols after you listen to my talk, that gastric residual volume is given less importance. So we'll go on to the actual talk now, and to dispel the myth that enteral feeding cannot be provided in patients with a high gastric residual volume. If you look at the basic gastric physiology, when food enters the stomach, especially solid food, there is a phasic and a tonic contraction that empties the stomach. And when the food goes into the small bowel, the stomach empties more. That is why when you have a nasojejunal feeding, you'll actually find that the stomach empties faster. And there is also a gastric pacer. Now, in our hospital, like ICU patients, the grinding effects of solids in the antrum is really not very important, because we actually give liquids, and the liquids empty very rapidly from the stomach unless there is a pathology in the stomach or there are medications that have affected the gastric motility. Studies have shown that there is no relationship between aspiration pneumonitis and pneumonia, ventilator-free days, organ failure, and mortality. And actually, studies have shown, the paper published in JAMA in 2013, to say that there is no need to measure, but it is very difficult to change nursing practice where you don't need to measure it at all. So what we try to teach is, try to convince the nurses and to show them categorically with the evidence that you don't need to stop enteral feeding with a gastric residual volume of 150 cc's or 200 cc's. Change the limit to 250 to 300 to 400, and then maybe finally to 500, which is the present guideline. Here is a study that has been published on 6 randomized controlled studies and 6 prospective observational studies, and the thresholds for GRV to avoid complications were studied. This was limited, of course, to mechanically ventilated patients, and this was a group in which the risk of aspiration is very high. Monitoring of GRV is unnecessary to guide enteral nutrition, was the conclusion of the study. And if for surgical patients alone, you can accept a low threshold of 200 ml, even anything 200 or 250 ml, you can safely feed the patient. Here is another study looking at the elimination of the measurement of gastric residual volume, not only in a university teaching hospital, but in a community hospital in critically ill patients. And the elimination of GRV measurements had no adverse effects at all on the delivery of enteral nutrition and on the complication. In fact, there was a greater percentage of prescribed nutritional needs that were met when you eliminate the routine measurement of gastric residual volume. And there was no difference in the adverse effects such as diarrhea, emesis, or glucohomeostasis. So the guidelines, both in 2016 and the 2022 guidelines, the Society for Critical Care and the American Society for Parenteral Nutrition guidelines, say very clearly that you must always assess the patient for risk of aspiration, elevate the head of the bed, continuous feeding, use of pro-motility agents like metoclopramide preemptively. That is all you really need, not depend upon gastric residual volume. Of course, I agree with you in selected conditions, such as diabetic or uremic gastroparesis, or when there are medications, narcotics that can delay gastric emptying, or known severe gastroesophageal reflux disease. In these conditions, you might want to use prokinetic agents and also measure gastric residual volume till you are comfortable that the levels are okay. In the prone position, for example, even though studies have shown that measurement of gastric residual volume is not really necessary, many physicians want to measure it initially and then be convinced that the GRV is not high and then go ahead and eliminate it completely. So when you think that the patient has a risk of aspiration and a risk of gastric residual volume, then at the bedside, you put in a nasoduodenal tube, the thin bore tube, which can be done by fluoroscopy or even by endoscopy. Even spontaneous passage of a weighted nasojejunal tube can be achieved by certain maneuvers like positioning the patient on the right side. Even when the patient has a gastrostomy tube, you can have a transgastric jejunal feeding tube so that you don't have to worry about feeding into the stomach. So the truth is, enteral feeding can be safely provided in patients with a high gastric residual volume and up to 500 cc's, if at all you want to measure it. But it need not be a routine part of monitoring patients in the ICU.